3, 2, 1.
Good afternoon and welcome to another episode of Hello Health. Sorry about the delay today. Had some short technical difficulties, but thank you so much to those of you that waited to tune in to our live series where we talk to some of your favorite doctors right here in the area. Now, my name is Grant Dodge and I'm with Health Benefits Associates. Health Benefits has offices here in Reno, Sparks, and Carson City to help with your health insurance and Medicare needs. We have our upcoming Mastering Medicare series, which is tuning in today at 3 o'clock, so please make sure to tune into that as well. This YouTube channel is posting that Mastering Medicare series as well as regular updates for health insurance in general. All sorts of changes going on all the time, so make sure that you don't miss a beat on our channel, which a great way to do that is to click that subscribe button below and click the bell icon next to that subscribe button that will appear. That will notify you for when we go live and when we post these regular updates. So please make sure to subscribe to that channel, and that way you don't miss anything in all these big changes going on, especially that Mastering Medicare series, which, by the way, is coming up right for the annual enrollment period. That is starting in 30 days, October 15th. So make sure that you tune in so you can talk to a Medicare expert just like myself. Now, before we get into today's presentation, I just want to make sure everybody understands to post your questions and comments down below. We will have our guest today go through their entire presentation, and we will answer those questions at the end of today's series, today's episode. So make sure to put those questions down below, and we will get those answered for you once we are finished. Now, on to our guest. Who is he? Today we have a very special guest, Dr. Jonathan Pezanoski with GI Consultants. Really excited to have him on the show today. I know this office is a big office here in the local area, and Dr. Pezanoski, he has been practicing here in the Reno area for 14 years. He specializes in gastroenterology, endoscopic ultrasound, and Ercp, which is going to be the main focus of his presentation today. Now, he completed his education at the Royal College of Surgeons in Ireland, completed his residency at St. Joseph Mercy Hospital in Ann Arbor, Michigan, completed his fellowship at Providence Hospital in Southfield, Michigan, and his advanced fellowship at St. Luke's Medical Center in Milwaukee. So let's see if we can get Dr. Pezanoski on the show today. Can you hear me?
Yes, I can.
Great. Well, hey, first and foremost, I just really want to thank you for taking your time. I know you are very busy, but I really appreciate you coming on the show today, and we are really excited for your presentation. I think this is going to be perfect for our audience today. So whenever you're ready, go ahead and take it away.
All right. Well, it's my pleasure. Thank you very much for the invitation to be on your show. People call me Pez because it's easier to say. And I do a lot of endoscopic procedures, and I see a lot of gastroenterology patients. Today, I'd like to talk about ERCP. So ERCP, first of all, is a specialized endoscopic technique to study the pancreas, bile ducts, and the gallbladder. ERCP stands for E for endoscopic, meaning that I use a scope to look down your throat. R for retrograde, meaning that I go backwards up the bile duct or the pancreas duct. And C and P is fancy Latin cholangiopancreatography. That's just a fancy Latin way of saying looking at the bile duct and the pancreas duct. Now, ERCP has lots of indications. A few of those would be treatment and evaluation of obstructive jaundice, evaluation of diseases of the pancreas duct, the pancreas and the bile duct, evaluation of strictures, either benign or malignant of the pancreas or bile ducts, and evaluation of bile leaks, just to name a few. Once we identify these problems, we can then also do therapeutics with ERCP, and that would include things like removing stones from the bile duct or the pancreas duct, dilating strictures or narrowing of those ducts, biopsies of these strictures, treatment of bile leaks if you have leaking bile into the abdominal cavity, and placement of bile duct stents or pancreatic stents. So usually if I'm going to do a procedure in ERCP with one of my patients, I draw them a picture. I've drawn that picture for you today. And I'd like to give you the speech that I give them directly, pretty much word for word. So here is kind of a cartoon of your bile duct. Your liver lies under the rib cage on the right-hand side. Your liver makes bile 24 hours a day, 7 days a week, and it travels down the bile duct to that little nipple right down here called the ampulla. Now that's a round muscle or a sphincter muscle. It's like your bottom muscle. It's closed off tight when it's not being used. Since it's closed off tight, the bile backs up, overflows into the gallbladder, and sits there and waits. Then when you eat a meal, food comes down the esophagus, into the stomach, it gets churned up, it comes into the small intestine, passing that ampulla. That gets a chemical signal to open wide. The gallbladder gets the same signal, and that squeezes, and then all of that bile comes down and mixes with your food. Here's where the story is a little interesting. Bile is almost exactly like dishwashing liquid. It's very slippery. If you mix it with water and shake it, it foams up. If you mix it with fat or with oil, it dissolves that fat and oil, just like dishwashing liquid. And that's its main job in the intestines, is to dissolve those fats and oils that you eat in your diet so that you can absorb those calories. Now, like dishwashing liquid, however, if you leave that bottle sitting on top of the sink overnight and you don't wipe the little drip off of the top of it, it gets kind of gummy. And the same thing can happen inside the gallbladder. And when that happens, we call that sludge. Now, that in and of itself can cause issues, because imagine trying to blow toothpaste through a straw. It can cause a blockage, it can cause pain, it can cause liver test abnormalities. If you leave that bottle of dishwashing liquid for a couple weeks and you go away on vacation, you come back, now that drip is hard as a rock. The same thing happens in the gallbladder, and for all intents and purposes, that's what gallstones are. And gallstones in the gallbladder, lots of people have them and they don't always cause issues. But if those gallstones get into the bile duct, they can cause a blockage, and you might need an ERCP. Now, in the olden days, if there were stones in that bile duct, you'd need a major surgery. You'd get a big incision, and with that big incision, then they open up the bile duct, they squeeze the stones out, and then you'd end up having drains hanging out of you for a couple weeks at a time. Nowadays, if you need your gallbladder out, the surgeon can do that with a keyhole operation, but then you're sent to me to get the stones out of the duct. And we do that with that ERCP. So our scope has a camera at a 90-degree to the angle, or angle at the tip, so we pass it fairly blindly down your esophagus after you're 100% asleep. Once we pass it down, we park that scope sitting right here, looking at that ampulla. Now here's looking sideways, and down here I made a little circle that's kind of looking head on. We then take a device called a cannula. It's shaped very much like this pen, but a lot smaller, and we fish it up into that bile duct. So here's looking head on, here's looking sideways. Once we get into that bile duct, we then can inject dye and use x-rays that show off that dye, and we can look for stones, we can look for strictures, we can count how many stones there are, etc. Once we see what we're looking for, then we make a small little cut through that sphincter muscle. And that cut is called a sphincterotomy, and that opens up that ampulla very wide. Now from there, we have different devices, balloons, baskets, other devices that are very tiny that we can pass down the scope channel up into that bile duct in order to crush stones, pull stones out. We have balloons that we can put across narrowing or strictured areas and stretch that open. We have small little biopsy forceps. We have brushes that are like tiny little pipe cleaners that we can scrape up through those strictures to try to see if there are cancer cells or malignant cells there. If there is a stricture or you have multiple stones, then we might place a stent. And a stent is a little plastic tube, I like to say, kind of like a small cocktail straw that goes across that area to hold strictures open and hopefully keep the bile duct draining. Now, if I do place a stent, then 3 months later, we do the procedure again. Some people, one procedure is all that's needed. Other people might have to come back, but that's the exception. Now, once again, we don't just deal with these bile duct stones. Let me draw something on my picture here. Sometimes people will have tumors of the bile duct or the head of the pancreas. So we're able to, once again, get into that duct, stretch it open, take those brushings past that tumor area. Now, in addition to ERCP, I also do a procedure called endoscopic ultrasound, and it looks like I have a little time to talk about that. So endoscopic ultrasound, or EUS, is a technique that combines endoscopy and ultrasound to obtain images of the digestive tract and the surrounding area. So indications for that, with endoscopic ultrasound, I can look through the esophagus wall for lymph nodes in the chest or other masses in the chest. I can look adjacent to the stomach to see if there's any tumors of the pancreas body or tail. Taking a step back, endoscopic ultrasound, my scope has an ultrasound probe at the tip that looks 360 degrees, kind of like X-ray vision. And so I like to say it's like having an imaginary paper cocktail plate at the tip of that scope. And whatever that plane passes through, I can see on my computer monitor. And so when I do pass that scope into the stomach and along the bottom of the stomach, I can see the pancreas better than any imaging. So the pancreas lies behind and below the stomach. Then if I see a mass, God forbid, or something else abnormal, I can take a needle and pass it through my scope channel, taking biopsies directly of that pancreas mass or lymph node or whatever abnormality I might see. With endoscopic ultrasound, I can also drain cysts and send that fluid for analysis. I can stage rectal cancers, esophageal cancers, gastric cancers, pancreatic cancers to look for how far they are along, because endoscopic ultrasound gives us finer images than a CT scan or an MRI or other imaging might give you. And that's basically the speech I give my patient. That's what ERCP is, and I hope I gave enough information.
Yeah, absolutely. Well, thank you, Pez, for providing all of that. Give credit to you, too, for drawing on the fly. I think that's the first time we've had an actual drawing or at least some sort of illustration here on this show. I'm sure that that's not the first time you've had to make that drawing before, though.
I've done thousands of these. Patients, I like to make sure that they have more information than I need. I like to say, honestly, I like to treat my patients like family, and I like my family.
Great, great. Well, looks like we got a handful of questions here today, but before we get into today's topic, just make sure that if you enjoyed our presentation today, let us know in the comments section, or make sure to click that like button so that we know to bring you more content like this here in the future. But let's go ahead and dive into those questions today. So the first one we have, it looks like we have Alice Gray. She has asked, what are the best ways to get prepared for an ERCP?
The only preparation that you really need is to fast for 6 hours. Our scopes go down the esophagus into the stomach, and we don't want to encounter a whole bunch of food for that. So clear liquid diet, preferably for 12 hours before the procedure, and then nothing by mouth for the 6 hours beforehand. Otherwise, no real preparation.
Got it. So it sounds like it's not doesn't need too much preparation, unlike other
Not like a
major procedures.
colonoscopy where you have to drink the awful fluid.
Got it. All right, great. Our next question here, it looks like we have Lynn Yu. She first asked, do you have to be awake for an ERCP, or are you unconscious? Some people feel that these types of things might scare them. So do you have to be awake?
No, you are completely asleep. Through my training, we used the same kind of sedation we did for upper endoscopies or colonoscopies. Now I insist that all of my patients are completely asleep with an anesthesiologist watching them like a hawk and monitoring them the whole time, because I want this to be a pleasant experience. And the worst complaint we usually get after an ERCP is a little bit of a sore throat. But I didn't mention ERCP does have risks, just like all the rest of the endoscopic procedures we do. Bleeding, infection, perforation, failure to identify pathology, meaning that no matter how good I am, I'm not God, things can be missed. And with ERCP, there is a 3% chance of causing pancreatitis. It's a small risk, but if you need the ERCP, the benefits outweigh that risk.
Got it. All right, thank you. Well, Lynn Yu also asked another question, if your office accepts AARP. I can handle that question. If you have specifics about Pez's office and whether or not for certain insurances they take, feel free to reach out to our office. We'd be happy to let you know whether their office accepts that type of insurance. But that kind of leads into my next question here. What's the best way to schedule an appointment with your office, Pez?
Our office, we have 3 locations. We have Carson City office, our Reno South Meadows office, and our office up downtown on Ryland. Our office number is 775-852-4848, and the phone prompts should easily get you to our scheduling department for an office visit or procedure.
Great. Next question we have here, Alex H. I know you just went over this, but can you please just make sure to reiterate the risks of an ERCP?
So the first risk is the risk with any endoscopic procedure, and that's anything you can imagine from taking a tube about this diameter, passing it down the throat, into the stomach, and into the small intestine. So bleeding, infection, perforation of the intestines, those are all very small risks. Failure to identify pathology, I like to say that I'm very good at what I do. Once again, I'm not God, so things can be missed. But small tumors, for example, stones can be left behind. Bile leaks could be undiagnosed. Those are very, very small risks. The risk of the sedating medicine is a real risk. We aim to make you very comfortable with what we do, but we want to make sure you're safe. So that's why we have an anesthesiologist with us monitoring your heart and your lungs. But there are the risks of anesthesia. And once again, pancreatitis. Your pancreas is an organ, like I said, it lies behind and below the stomach, and it makes pancreatic enzymes. And those enzymes are digestive enzymes. They digest fat, protein, and sugar. Well, your pancreas is made out of fat, protein, and sugar. So if the pancreas gets angry and those enzymes get activated, it basically starts eating itself, and that's what pancreatitis is. Now, 9 times out of 10, nausea, vomiting, pain, you get better in a couple days. 1 time out of 10, severe enough to put you in the intensive care unit. That's very rare with ERCP. And with gallstones, if you have a stone blocking the pancreas duct, 1 time in 100, it can kill you. And I've seen people die from gallstone pancreatitis. So that's why if you have stones in that bile duct, we do this ERCP to try to remove them.
Great. Well, it sounds like this is certainly a very important procedure. Now, getting into our next question here, Jose, looks like, first off, he did like your drawing, and he said that are there any other sorts of procedures besides an ERCP that can give you the same results that you would get, or at least find some of those abnormalities that an ERCP would reveal?
Yes, there is a procedure called an MRCP, and that uses MRI, an MRI machine, to give you the images of the pancreas duct and the bile duct. And that's very good. So it's good for looking for stones, it's good for looking for strictures or masses, but it's strictly diagnostic, meaning that it might find those items, but it can't do anything to fix it. Now, With therapeutics, I mentioned surgery at the very beginning. That's very invasive. ERCP is much less invasive. There is a procedure called a P2C, where the radiologist would stick a needle from the outside through your liver into the bile ducts from that direction. But then you're left with a drain hanging out of you for a while. And that's not the best test in the world for taking out stones, and it's not the best for dilating strictures or biopsying them.
Great. All right. Great to know. So when you're performing an ERCP, it looks like this question is from also from Alice Gray. What do you usually find, or what's the most common abnormality that you would find when you're performing this procedure?
So the most common one is bile duct stones, and that's why my speech is pretty heavily weighted towards bile duct stones. They're surprisingly common. I couldn't give you an exact percentage, but I'd say 8 out of 10 ERCPs that I do are because of bile duct stones. The other 20% are due to strictures. Unfortunately, pancreatic cancer, we see a lot of that.
Okay. Let's see here, just making sure we have all of our questions answered. It looks like we do. So thank you once again, Pez, for taking your time today. I know we ran a little bit over for our start time, but just really want to appreciate you and your office working with us to be on this show. It's always great to have a lot of our community doctors here, so really thank you so much. Appreciate having you.
My pleasure. I always like to educate. Thank you.
Great. All right. Thanks so much, Pez. Talk to you soon. All right. Well, that is going to be it for our presentation today, but you should be able to view our Mastering Medicare schedule here on our show. That is upcoming today at 3 o'clock with Matt Law. That will be, once again, a topic about how you can get ready for that annual enrollment period for Medicare and some of the tips and tricks that you need to know before you hit that October 15th start date. That's with our Medicare specialist, Matt Law. So make sure to tune into that and to subscribe to our channel so you get notified for when we go live next. But thanks so much for watching today. If you watched all the way to the end and you waited around for our start time, I really appreciate it. My name is Grant Dodge with Health Benefits Associates. Talk to you soon.